Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by two physicians, Dr. Sweta Singh and Dr. Rebecca Sevier. Dr. Rebecca Sevier is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and hospitalist program leadership, Dr. Sevier is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Care Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare makes her insights invaluable to listeners eager to learn and grow in the medical field. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations. Today, we have selected two intriguing cases to discuss. Dr. Rebecca Sevier will kick us off by introducing our first case.
Okay. Well, it's good to see you again, Sweta. We're going to go through a case. This one that I have for you is a little bit longer here, and it's actually one that got sent to my team 2 months after the patient was in the hospital. So I'm just going to throw that out there to start. So this one's a little different. So I'll go through some of the background. So this was a 73-year-old female who came to one of our hospitals for an elective procedure. She was going to be undergoing back surgery involving the L2 through 5 laminectomy with a bilateral medial facetectomy and foraminotomies, and an L4 through 5 pedicle screw fixation and fusion. So again, planned procedure. It was traditional Medicare, so there was no additional auth required for that. And this came to our physician advisor initially on hospital day 1. The PA at that point reviewed the case. The first thing that she did was, she wasn't sure about the procedure because there was multiple levels. She was concerned that maybe it could be an inpatient only. So appropriately, she sent, we have what's called a stat or coding email that we can use to have a case reviewed very quickly to help identify any cases that could be inpatient only. So she did that right away. And they got back to her and said, nope, it's not an inpatient only. And at that point, she didn't see a lot going on with the case. So she recommended to downgrade the patient to outpatient in a bed, which is the status we use for our post-op patients. I know some hospitals have other, statuses they use, but for all intents and purposes, they're all just an outpatient status. So I guess I'll pause there. Again, we got the case both concurrent and then retroactively to look at. But I guess if you were managing this concurrent, anything stand out for you, Sweta? Anything, pique your interest in how it's been managed so far?
I agree with you that post-operatively, if it was uncomplicated surgery, it's not on an inpatient OB list and is an outpatient procedure. We also use whole IV or sometimes extended recovery, but still it's the patient class we label as OIV for these procedures. If no complications, because, or let me put it this way, if no unexpected complications, because some pain, some nausea, vomiting is expected, and it's still part of the OIV recovery and management. And if there was no significant use of much IV antiemetics or IV pain meds or anti-leukotrienes are as per protocol, just perioperatively with we're not monitoring for any cultures or anything to plan out keeping things longer. It's appropriate to start it as OIB and let's see how things go.
Yeah, and I looked through the surgical notes as well. I couldn't really tell what the surgeon was expecting for that postoperative course and duration. They were on antibiotics per protocol. The patient did have a drain in place, and the plan was for them to go home with family. That was kind of the information that our physician advisor had. I'll make some comments later, given how this played out, but the case goes on nevertheless. So hospital day 2, we the patient still has a drain. They're still on IV antibiotics, and they were noted over that first night to start to have some intermittent hypoxia. They thought this was just atelectasis. Now the patient, it was being monitored by our, at this point in time, our case managers were doing both our UM and discharge planning. So they were the ones doing the review. So they were seeing this case, but it wasn't sent back to our PA. So hospital day 3, patient's still here. Patient's not doing so well with ambulation. She's just not mobilizing well. She's just not getting very far with that, but not necessarily needing big doses of like IV pain medication, but just not moving well with everything going on. Still at that point in time, plan was for the patient to go home with their daughter, but they needed to work with her on getting that a flight of stairs. She needed to be able to get up. So then now hospital day 5, it does get sent back to the physician advisor at the site and asking if the patient should remain in an outpatient status. It does look like at some point in there they got the patient to observation, but didn't ask the question. It was traditional Medicare, but they did not convert to inpatient. So, but on hospital day 5, the PA said because of the ongoing issues with the mobilization and the hypoxia, they would recommend converting to inpatient. However, it wasn't until hospital day 6, for whatever reason, the physicians, they were asked to put in the order. The surgeon did not when we asked them. So it was the next day. And then unfortunately, on hospital day 6, it was now determined that the daughter is not going to be able to take care of the patient, and the patient now needs SNF. To go to a skilled nursing facility. So again, traditional Medicare. And so we did get a new order for inpatient on hospital day 6. And then the patient discharges on hospital day 8 to the SNF. So, any thoughts on what I've told you so far?
Yeah, and I can see the discharge happening. So, like I said, getting that maybe reviewed on day 3 would have been preferred, because by that time 2 midnight already met, right? We had the first midnight requirements last for the monitoring, and then patient had hypoxia, continued pain, reduced mobility. So continued care needs. And if you go by the SNFs coverage by the Medicare, need for 3 inpatient midnight that goes from the inpatient order, right? And so that would have been nice to have that sooner, so there would be more, even though it's a DRG payment, but and 2 midnight requirement for medical necessity for determining inpatient, that can start from when the care started. But unfortunately, still for the SNF and SAR placement, the requirement for traditional Medicare patients is to have 3 inpatient midnights for them to be eligible for full coverage for the subacute rehab or skilled nursing facility. So I agree with you. This would have been nicer if this had come on day 3 rather than day 5, or this would have had, as soon as we determine, we could have done that admission order. And especially, we also sometimes struggle with that. Getting the providers to put in an inpatient order when patient meets the criteria, because not everyone understands the importance of it. They're like, we're busy taking care of the patient. This thing can wait. And then, oh, too bad, I forgot about it. Oh, look, that's not how it works.
Yes.
So identifying a lot of these cases definitely is one of the key. The sooner we get that referral, it will be better And then we do have an escalation pathway, at least in our institution. What that means is, so our utilization review nurses will send a message to the provider, and then they'll send a reminder in 30 minutes, then in 1 hour, and after then escalate to the supervisors, and it's still no response, then they would escalate to the medical director for care management, and then we reach out to the attending. Hey, can we get the orders, please? Do still some cases fall through the crack and get pushed to next day somehow? Yes, but majority we try getting the admission order same day. So that's my take.
So, well, I agree that just with the initial part of this, there was so many process improvement opportunities here. As you said, it really should have hospital day 2, should have went back to the PA, should have been upgraded then, and also, should have been followed up on. Our processes, typically our nurses or our case managers should own getting that order in place. And if they don't, then they need to, they reach out to the PA if they're having trouble. Our PA didn't know that they didn't get the order, so that wasn't escalated. So again, all of these things didn't happen. As a result, the patient did discharge with only 2 consecutive midnights in inpatient care. So I get the case, though, 2 months later, and you might guess why I got the case 2 months later as a medical director over our whole state. And that is because there was a SNF denial. Apparently the SNF didn't recognize the patient did not have 3 consecutive inpatient midnights and accepted the patient, tried to bill out the stay to Medicare, and Medicare comes back and denying. And the patient was not very happy about that. So hence it became a patient complaint for us to evaluate. So I took a look at the case, and I guess a couple things for me when I was looking at this case. I went back at the very beginning to just take a look at everything, see when the orders were placed, see when we went from in to outpatient and back to inpatient, and check the timing of all the orders. And I did find that, again, it was inpatient on the first day, downgraded to outpatient same day, was not upgraded till hospital day 6, and did discharge on hospital day 8 with only 2 midnights. And the PA did, evaluate, make the recommendation. The physician did agree and put in the order. The case manager documented it. But what did not happen, and this is kind of an interesting part of this case, I haven't had too many of these in my career, but occasionally, is that, I was looking to see, was this a valid, admission code 44? And it had most of the pieces, except there was no notification to the patient of the change in their status. So they were not aware of going from inpatient to an outpatient. So we have a process for this that normally should have been followed, but it wasn't. There was no documentation of, any notice being given to the patient. And this was traditional Medicare. So in order to be compliantly downgraded from inpatient to an outpatient status, whether that's outpatient in bed or OBS, you must have notification to the patient. That was not done. So that made this downgrade not valid. So we were able to go back to, it was appropriate for inpatient from the very beginning because we did not follow the correct code 44 process, which in this case turned out great for this patient. So again, this was a really good case to learn from. We had so many opportunities here. I did have compliance weigh in on that too. When I typically, when I'm dealing with some of these cases that are a little bit non-standard, and I always want to make sure we're managing these very compliantly, I will frequently run these past our compliance department, depending on the situation, and just make sure they agree. Because the last thing we want to do is, something that's not truly compliant. We want to make sure it's the right outcome for the patient, but it does have to follow the Medicare rules. So I don't know if you've encountered this situation, or maybe you have other thoughts on that. I don't know if you would have gone the same way or.
No, I think, like you said, these are not that often happen. So I have personally not encountered, but definitely I learned a lot. For example, I didn't know if we do not go through the code 44, the downgrade is not valid, and because at the end this was still determined to be inpatient appropriate, that we could say it was inpatient throughout. The initial inpatient order then still stands valid, right? And and at the end of the day, CMS rules are in place to help the beneficiary, the patients. At the same time, we want to stay compliant, and the compliance pieces in so that we can make sure that hospitals are following proper procedures and rules. So that's a smart move to look back that inpatient to outpatient, that process went through okay, or how did that go in the code 44. So I don't think I have any additional thoughts other than that's a good learning experience and learning for me as well. Thanks for sharing that case.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers, join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org/membership to learn more. Let's continue with our second case.
I know you probably have another interesting case for us, so...
I do have one case, and this is a little bit lengthy. So this is, again, Medicare patient, and we are doing this on day 3. So this is after the 2 midnight. It's an 83-year-old patient with a history of chronic kidney disease, heart failure, protein C deficiency with prior TBT, and is on aspirin and Plavix. As carotid artery disease, presented to the ED for evaluation of lower abdominal pain. He recently had the right hip replacement about 5 days before the admission, this ED visit, and course was complicated by post-operative urinary retention, for which patient was discharged with a 40 catheter. And concomitant UTI, which was recently treated with macrobed. So they also started the patient on macrobed. In the ED, patient was hypotensive with 70s/40s, but significantly improved with 3 liters of resuscitation with 3 liters of fluids, and is now otherwise hemodynamically stable. Labs showed metabolic acidosis on arrival, 7.2, lactic acid 3, but again with those fluids, it resolved to normalized. And initial hemoglobin of 7.7, but no active bleeding. And patient did get 1 unit of blood, but then improved hemoglobin to 10. So possibly hemoglobin was better even before that unit of blood. Metabolic panel was consistent with metabolic acidosis and some elevation in creatinine, and urine analysis with leukocyte esterase, RBCs, WBCs, Highland cast. And again, patient has some week-old folly on which and is already receiving the outpatient macrobed. So from hypertension point of view, and with the AKI injury, the patient already got the IV fluids, and the initial H&P said no concern for sepsis. However, most recent progress note are said doubt sepsis, and renal function, blood pressure, everything improved. In total, patient got the 3-liter initial IV fluids in the ED, and then about 1.5 liters more with some continuous IV fluids. And those IV fluids were stopped the following day. Was put on IV cefepime, so at least that is going on. And then really the concern was thought to be more of post-op ileus, and that patient, that also improved. Patient had multiple bowel movements on day 2. So now things have all resolved or resolving, and this case is coming, I know, on day 3 now. It's like, okay, if I was reviewing this on day 2 and with all that finding in the morning, I would have probably gone more towards the inpatient. But now that we are monitoring this case was initially admitted as an observation, and we are reviewing on day 3 that patient. Do we think it should be converted to inpatient? What do you think, or what additional questions would you have for me?
Yeah. So again, traditional Medicare, and the status is still obs when I'm getting it on hospital day 3. Is that correct?
Right.
Well, what I always do with my traditional Medicare cases is I would back up, to hospital day 2, because if we started as obs, I'll back up to hospital day 2 and say, hey, what is going on in hospital day 2? And is that second midnight, medically necessary? So that's what I'll dig into. Definitely if the case has started out as inpatient, I'll review, go back to, what was going on when we placed that inpatient order. But here we're trying to establish, the patients had 2 midnights. We need to just make sure that they were medically necessary and patient was not staying here for non-medical reasons. The daughter couldn't come pick them up, for example. But in this case, I personally probably would have started him as inpatient, but we didn't. This guy was pretty, sick, with the labs were, we had multiple metabolic issues. We had low hemoglobins and hemodynamic instability, needed a lot of fluids, this post-op ileus. So it sounds like on hospital day 2, the guy was looking better, but not completely resolved. Still needing to have, some more monitoring and make sure the ileus is resolved, oral intake's adequate. I'm not sure exactly where, all the, lab numbers were, but I'm suspecting that all of them were back to normal. So it sounds like this guy was pretty elderly, 83. So it's also one that, even if they're showing improvement, you do want to make sure that they are really on that home stretch and are going to be good to go. I think I would feel uncomfortable with a guy coming in this sick that in 24 hours, they were just perfect and ready to go. So on hospital day 3, even if we were going to discharge him, I would go ahead and say make it inpatient. So were they going to discharge him on hospital day 3?
That's what we were most worried about. That actually made them now inpatients with the good chance that the patient would be discharged and then the same day. Well, like you said, sometimes it's a good idea to just back up and see what was happening on day 2. Was that second midnight medically necessary? They took it careful. They did stop the IV fluids on day 2, and patient has started having bowel movements on day 2. So, but like you said, sometimes these things happen more later in the day, and still you need monitoring because they came pretty sick, and these elderly with the recent surgery, and IV cefepime was still continuing because they were still not know if we ended up discharging the patient on day 3 or day 4. But like you said, even though sometimes by the time we review the case, the tricky part is if they look now too good to be looking like inpatients. So reviewing them sooner definitely helps, but this came to us more after the second midnight, and because there was still need for second midnight medical necessity, we opted for inpatient. My question now comes, the harder part is, say this was not a traditional Medicare, and then we are reviewing for a commercial payer. Some of our commercial payers like to see a care need beyond the 48 hours. Have you run into those? They're like, oh, they continue to need these IV, or they look sick again, sick even beyond the 48 hours, that's when they are interested in calling them inpatient. Their labs still look bad, or they still have some blood pressure issue or some tachycardia. At least initially, a lot of my peer-to-peer experience was that, tell me on day 3, what were the vitals? What were the labs? What were the concerns? What would you do if this was a commercial payer?
Yeah, I think, you hit on the key, similar to, I would approach it very similarly. I think I would, a lot of our payers for our commercials, they're not bound by the 2-midnight rule and tend to look at more obs, more 48 hours and want to see the patient going beyond 48 hours, needing that intensity of service and the severity of illness. So, I still like to look at these patients on hospital day 2. Our usual workflow is if our nurses cannot get it to inpatient on hospital day 2, and the patient staying for medical reasons and not pure social, it needs to go to the PA to be looked at. That's how it's supposed to happen, for this very reason that we need to see what's going on. And if the documentation just isn't capturing, what's going on, that's our opportunity to get it in the documentation. It's much harder to have very bland documentation for the whole stay and then maybe add a little sentence in the discharge summary. It's much better on that day for the physician to capture what's still going on, what are they worried about, why does the patient have to stay, then try to make the case after the fact. So that's probably, this is one where if I got it on hospital day 2, I would have, tried to make sure hospital day 2's notes captured what was still wrong with the patient. And I might have had him push the inpatient, knowing that, we would have been going past 48 hours. I would have tried to kind of feel out the physician, how much more do you think we're going to need to do? How long will the patient need to stay? Those sorts of things. But, it is a little bit harder if you get it on hospital day 3 and the patient looks pretty good. All these things are all better and they're maybe staying because they're a little bit weak. That becomes a harder case at that point if you haven't already converted them. So I don't know. On this one, I would struggle a bit if this were a commercial payer. I'd really have to dig into hospital day 3 events and exactly why they're needing to stay, beyond 48 hours. So I don't know do you have other thoughts or?
No, I agree with you, Shruti, and they've just said sooner the better. So like in documentation of the medical necessity or what's keeping them still in the hospital is the key here. And once they've already passed that 48 hours and they're still, if they have continued care needs, it's much easier to argue. Now, do we convert them to inpatient on day 2 and then send it to the payer? Do they still deny and say they want to see beyond? Yes. And then I try to argue that the patient improved in the observation period, 48 to 72 hours. It wasn't much out. We do get to see those too, but I think the key here is, like you said, they had continued care needs, and there are 3 things what we are looking for: medical necessity, severity of illness, and intensity of care. And if you meet those 3 criteria, it's worth calling them inpatient.
No, definitely agree. Well, again, great case, and I think thought-provoking, and so I appreciate you bringing the case today. So thank you.
And thanks for discussing with me. It's been pretty good learning from your case too. We'll definitely look into our process too.
Yeah, that one was a unique one for me as well.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Dr. Sabir and Dr. Singh for sharing their cases and insights in this episode. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes.